For some of us, getting an appointment with our primary care physician has been difficult since the pandemic. After 2 years of stay-at-home orders, doctors' offices have now become flooded with all of us trying to catch up on our health. But as the patient demand grows, the number of available doctors continues to shrink.
Primary care is really a field in crisis, and it's in crisis for a number of reasons. And a major one is really around workforce, where we have fewer students than we actually need going into primary care. It turns out that we need about 40% of medical students to be going into primary care to really meet our needs, and the numbers are unfortunately, much less than that.
That's Dr. Russ Phillips, a primary care physician and director of the Harvard Medical School Center for Primary Care. He says a main reason for the shortage is the fact that the high demands of this career are not nearly as well paid as many other medical disciplines.
Trying to sort of drive students into a choice where they're being asked to work incredibly hard for low compensation, as you can imagine, is very challenging.
Dr. Justin Porter is an assistant professor of medicine at the University of Chicago. He's the lead author of a paper recently published in the Journal of Internal Medicine that exposes the unmanageable expectations of primary care physicians. When Porter was a resident, he noticed a large discrepancy in the care he'd been trained to deliver and the realities of his career.
So, when you're a medical student and a resident, you're taught to take your time, you're taught to, look at the small details, you're taught to kind of go where the patient leads you. And all of these things, I think, are absolutely important and absolutely critical, providing good quality medicine. But I found it's impossible to do a lot of these tasks appropriately in a 15 or 20-minute clinic time slot.
So when conducting the study, Porter decided to approach the issue differently than just looking at the demands of a doctor. Instead, he started with the patients.
What are all the services that should be provided ideally to an individual patient within that panel? So all the preventive care services that the USPSTF recommends, how long it would take to provide, chronic disease care for all the issues they might have, any acute care issues that come up, and then obviously the paperwork, inbox management that goes along with that. And then kind of comparing that calculation of time to just the realities of a clinic workday. We only have a certain number of hours in clinic. We only have a certain number of days in a week.
From there, Porter and the other researchers explored options that could close the space between ideal treatment and real-life experience. They looked at 2 similar studies from 15 years ago that respectively examined preventive care services and chronic disease services. And though these papers are widely cited, Porter says many factors have changed over the last decade, and the studies are no longer an adequate representation of the field. One of the most important updates is the practical breakdown of a physician's workday.
There's a lot of data that has now come out about how long it actually takes to do these particular tasks, in the same way that this data really wasn't available 15 years ago. So what does that mean? That means that the United States Preventive Services Task Force, which is kind of the gold standard for recommending preventive care services to primary care providers, has done a lot of research, on kind of which tasks should be done, what is there evidence for. But in the results of those studies, if you look deeply into them, they actually often record how long it took to do this particular task.
Meaning that there's finally concrete data on the time commitment of specific responsibilities. Though this level of detail didn't exist for every task the team included in their paper, they were able to make educated assumptions on the time it would take to perform other types of care. The final results of the study were divided in half. One part looked at the time requirements of a typical physician who works alone, while the other explored the outcomes if the tasks were handled by a perfectly functioning team of health professionals.
If they worked alone, we found that it would take about 26.7 hours per day to provide care for a 2,500 patient panel, which is a reasonable panel size, or I suppose one considered an unreasonable panel size, but it's certainly a common panel size found in the community.
Porter says the average primary care physician sees around 25 patients a day, each with a 15 or 20-minute time slot.
And then if you think about it, that if you're seeing 25 patients a day, over the course of a week, you're seeing 125 patients, you can certainly see how this can get out of hand very quickly, given all the services that need to be provided for all these patients, and then the follow-ups that need to be organized and scheduled. And if there are lab results that are abnormal, well, you have to call them back. And if your patients are scheduled back to back, 2 chunks in a day, it's very hard to kind of do all this work.
Porter says other doctors that he's spoken with feel the same way, showing how his research accurately depicts the real-life experiences of many physicians. And even if it were possible to work more than 26 hours each day, patients don't want to be cared for by exhausted and overworked providers. So how can the workload be reduced?
I think there are things that individual doctors can do to improve our workflow, but I think if you look at this paper, the solutions go beyond just simply changing our workflow and require much more systematic change.
A change that Phillips had aimed for when he helped create Harvard's Center for Primary Care more than a decade ago.
What we've been working on in the Center for Primary Care at Harvard Medical School is really thinking about how primary care really needs to be totally redesigned in order both to realize the value of primary care, which, I really define as sort of improved quality, reduced costs, while also addressing issues of equity, of workforce burnout, and clearly patient experience.
Which brings us to the second half of Porter's findings, a perfectly functioning team-based care model.
Historically, primary care providers have been considered responsible to do all these tasks for all of their patients. But I think there's been more of a recognition as, in the past few decades that, primary care providers are kind of very important members, but members of a kind of a healthcare team, which includes, nurses, pharmacists, physical therapists, case managers, counselors. So, we're kind of one of those members, and there are certainly these other members of the care team could provide a lot of these services as well, sometimes in some cases, maybe even better than the primary care provider.
So the question becomes, why aren't other resources like nurses and dietitians being utilized? Porter's paper broke down each task to see which member of a care team was best suited to handle it, instead of throwing everything at the physician. The researchers found that using this method could drastically improve overall productivity.
With all of that taken into account, the total amount of time that a PCP would need to spend for the same 2,500 patient panel declined by over half. So it went from 26.7 hours per day to about 9.3 hours per day. So we're almost getting kind of into a full clinic workday at that point.
Unfortunately, switching to a team-based care model isn't an easy change. Porter says that the current funding system makes it difficult for primary care physicians to support this approach.
The challenge is, Medicare and Medicaid often doesn't compensate either at the same level or at all for a lot of these interventions if they're done by members who are not a PCP. So, for example, and going back to counseling interventions, dietitians are only compensated by Medicare or Medicaid if they perform dietary counseling on patients that have just a very small number of conditions. I believe it's if you've had a renal transplant or a kidney disease, they can be compensated for that, but certainly not if you just have obesity and nothing else.
Which means that the physician would have to pay out of pocket, an expense Phillips says is not something many can afford. In order to make a real difference in the primary care model, he believes the entire payment system needs to change before true progress can be made.
Right now, primary care is supported through a fee-for-service system where the fees are lower than for most other specialties, resulting in low compensation. And if we pay primary care spends differently so that we're not necessarily using that fee-for-service approach, we can move to what's really called value-based payment, increase the level of payment, and have primary care physicians really doing work that adds value to the services they provide and the work they do, as opposed to being focused on trying to generate sufficient volume to support their practice and support their work, which is what happens through the fee-for-service system.
Porter agrees that more emphasis will be put on patients' health if primary care switch to value-based care,
where you basically compensate physicians and health systems for value metrics, providing not only just providing a service to a patient, but ensuring that they're actually healthy and have good outcomes. And I think if you focus on that kind of approach, providing value-based care, again, the devil is always in the details of how you do this. But theoretically, if you focus more on outcomes rather than services provided, you would start incentivizing higher quality care and more team-based care.
So instead of the physician trying to grow their revenue by increasing the volume of patients, they become more focused on the health of fewer patients. But this isn't the only answer. Porter says increasing funding is just one aspect of a solution that also involves system-wide change. Primary care has been proven to increase life expectancy. Yet it's a field that both Porter and Phillips say is underfunded and understaffed, issues that need immediate attention.
As healthcare leaders, we can transform the primary care system so that students who go into primary care have the opportunity to really help our patients realize the promise of primary care and do so with a job description and work that is really manageable, which enables them to go home at the end of the day, hopefully enjoy their family, come back to work the next day refreshed, and really feel that they're inspired and satisfied by the work that they're doing.
You can find more information about Doctors Justin Porter and Russ Phillips on our website, radiohealthjournal.org. Our writer-producer is Kristen Farah. I'm Reed Pence.
Coming up next week on Radio Health Journal.
I gave birth. The only difference between me and what feels like everyone else is that they were able to go home and put their baby in the nursery, and I was not able to do that.
The conversation around stillbirths that's long overdue.
Then cutting-edge technology that's helping improve communication for the physically disabled.
So instead of communicating one letter at a time, we could instead use this technology, and instead of going letter by letter, have the computer read out word by word the words that they're trying to say.
All that and more on Radio Health Journal. I'm Reed Pence, the producer and host of Radio Health Journal. If you like listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
The broccoli lobby isn't a very powerful political force, whereas the cattle lobby really is, and the sugar lobby really is.
Rebalancing our food production efforts. Then,
I think life should be enjoyed, and I think that there are pretty simple habits we can build into our lives that can make any given day feel better.
The time management habits that stack up to make a big difference. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Radio Health Journal and Viewpoints on your favorite radio station. And subscribe and listen anytime on Apple Podcasts, Google Play, and Spotify. Also, follow us on Instagram and Twitter at Radio Health Journal.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.